One of the things that we'll be focusing on this quarter and pretty much all of the upcoming quarters in the program is documentation. So you started out in PTA 101 learning documentation. Now we're going to spend time refining it. So this quarter, of course, we're documenting physical modalities because that's what we're learning about. So we're going to focus on, I'm going to focus here on just documentation in general, a little bit about modalities, and then as we discuss each intervention, I will speak specifically about how to document that intervention. As we add more skills, we will also add more documentation skills. So the learning objectives for this part are to be able to, and really forever, are to be able to document physical modalities in a SOAP note format in an accurate and timely manner, to be able to report the appropriate CPT code for each PT intervention you learn, and to be able to accurately record the billing units for each treatment section. So the goal these days in the real life clinic is point of care documentation, or as close to that as possible. You're not documenting what you did yesterday, you're documenting what you did today. Hopefully, in the time that's very close to when you actually did something. Hopefully that makes sense. Reporting the appropriate CPT codes for each PT intervention you learn. I'm going to list the ones we'll use for modalities. You should be able to record the billing units for each treatment section. Actually, this is an evolving process. I know the billing sometimes seems nonsensical, but it makes more sense than you think. And it's an art, not a science. So we can develop it. So you're going to be documenting treatments for all of the patients you treat, whether it's in the lab on a fake patient who's your classmate, or in the clinic on a real patient that you're actually working with. As healthcare professionals, we all understand that one of the most common challenges, especially when you're busy in the clinic, is to be able to write strong, defensible documentation that reflects the full scope of care that you're providing and the skills that you're providing. Whether you're completing a daily note or gathering data for a progress note, clarity, specificity, and clinical reasoning are all essential, and they all have to be represented in the note. So all OTs, PTs, PTAs, OTAs need to be able to do this. Your documentation isn't a record of what the patient did. It's a clinical and legal reflection of your reasoning as a provider. Well-written notes help justify medical necessity, support reimbursement, and guide future treatment decisions. So the next person that sees this patient and is reading your note should get all the information they need, and we should be able to include all the relevant information without being too wordy, too verbose. For each case study or lab practical that we do in the lab this quarter, you'll be provided with information similar to what you would see in a PT evaluation. Using this information, you will decide how to treat the patient, what modalities that you'll use, and how to document that treatment. So basically, if it didn't happen, don't document it. And if it happened, have the data to back up what happened. You have to document what you did and not write down things you didn't do. I know that sounds obvious, but keep that in your head. In school, sometimes you have to put in a little bit of creative writing because we don't have real patients with real injuries or motion restrictions. So you might measure your classmates' range of motion and it's normal, but the patient that they're representing, the fake patient or the case scenario, doesn't have normal range of motion. So you're going to have to make a few things up, but make up things that seem reasonable for the evaluation that you've been given or the case study that you receive. So as we know, SOAP stands for Subjective, Objective, Assessment, and Plan. There are some little subsections that we'll talk about briefly, but this subjective section will be included in all of our notes, and that includes the patient's current status and subjective data. That's what the patient tells us. However, unless you're doing a direct quote from the patient, it is okay to use medical terminology in the subjective section. Well, if they say medical terminology, you can direct quote that too. Objective data is essential. Many of the things that you learned last quarter in tests and measures and in your procedures class are objective data, including postural assessment, all the measurements we learned, all the sensory testing, levels of assist, transfers, that's all objective data. The things can go in objective data, and I'll talk about them in a minute. The treatment section is a subsection of the objective section. So it's not necessarily objective data, but it's part of the objective section. It doesn't take the place of measurable, repeatable data, which you will put in your measurements. You will, in the treatment section, state specific treatment interventions you used, the how the patient responded to them, and you're also going to tie it back to the treatment plan with clinical reasoning, state why you did it or the indication that caused you to choose that particular modality, and how it applies to the patient's goals. So you might choose a heating modality to increase tissue extensibility to work towards the patient's range of motion goals. So that's all going to be included in the treatment. Common mistakes people make while writing notes include repeating the same note with no update on the patient's progress. You don't want to do that. If you write down the same thing you wrote last time and you don't say anything about the patient's current status or their progress or their lack of progress and the reasons for it, don't another common mistake is using vague phrases like patient tolerated treatment well. You will see that when you go to the clinic. You'll see PTs and everybody else writing that exact phrase. I would never like to see you writing that. If you write that in your soap notes in class, you'll hear back about it from me. If the patient hasn't made progress, you have to describe why they're not making progress. It might be cognition or specific symptoms that impact performance, like pain. Why didn't the patient do this? Well, is it because they have cognitive issues? Is it because they have other issues? Specific symptoms can impact performance. It could be pain, it could be something else. So you're going to document all that stuff. You always want to include clinical words that demonstrate skilled care, and we have some activities this quarter that we'll practice those. If you don't include those words and instead use a bunch of other words that don't document skilled care, it's not a good note. So make sure that you include clinical language in your daily notes and progress notes, even though they have to be understandable to a wide range of people, different interdisciplinary communication between different professions and the patient and the insurance adjusters. You still have to use clinical language, but don't get so into the PT specific language that other people aren't going to understand it. So here are some things that you want to include. So let's just say you did therapeutic exercise. You're not just going to write down the exercise, say quad sets times 10, because that doesn't show skilled care. Who did the quad sets? Did you do the quad sets? Did the patient do the quad sets? Why did they do it? What were you doing while the patient was doing 10 quad sets? Instead, you could say that you instructed the patient in isometric quad sets in long sitting to improve knee extensor strength and standing stability. Ideally, it links back to their goals and you state the skilled thing that you did. So for manual therapy, say you're doing soft tissue mobilization or myofascial release, which you are going to be learning in your first and second lab this quarter. So you might say that you did you could say STM for soft tissue mobilization. It could mean something else out of context, or you could say MFR for myofascial release. Sometimes people write STM/MFR. So you're going to say where you did it. So soft tissue mobilization to the scapulothoracic region to reduce pain and improve shoulder range of motion for doing overhead tasks. So that ties it back to their goals of being able to do overhead tasks and clearly states what the skilled intervention was that you did and why you did it. You're also going to state patient's positioning and some other things, but just basic on that. Another example of how you're going to document skill, patient education on proper lifting techniques during a simulated mobility task, sit to stand holding a 5-pound dumbbell. Patient requires moderate verbal cueing to maintain safe lumbar lifting posture. So this phrasing shows that the patient wasn't able to do the task without cueing from you, and that you provided education on proper technique. The next time you see the patient, your note may say that they needed less cueing. I like to do percentages for cueing. So patient required verbal and tactile cues 50% of the time to perform this task with proper positioning. And then the next time, maybe I write patient required cues only 20% of the time to perform this task with proper positioning. So this documents improvement and it shows the need for skilled care. Those are just some examples. We'll talk about more examples. So I'm going to talk, let's talk a little bit about the individual sections of the SOAP note. So the subjective section, this is the part where you talk to your patient about their progress and their barriers. It's not just small talk like, hey, did you see the Seahawks game? You actually want to see how they're doing and get their take on it. So that has to include reproducible functional application related to the patient's main limitation. So these are things that the patient may have told you that are relevant to document. How did they do after their last visit, or how they responded to the previous treatment? Don't use the words, write this down, patient complains of, or PTC/O. Don't do it. Use patient reports instead. It complains has a negative connotation, and we're going to take that out. So use patient reports. Don't be repetitive. Once you say patient for the first time, you can switch to pronouns. You don't have to write patient did this, patient did that, and patient did this. Note functional limitations or functional gains, aggravating or relieving factors, improvements that they've experienced that they'll report to you. People are excited about their improvements, and a lot of times they'll come in and say, hey, I was able to put my hair in a ponytail, or hey, I was able to tuck my bra without turning around to the front, or whatever. So there's functional improvements. So you might, this is an example, you could say patient reports 5 out of 10 pain in left knee after 10 minutes of ambulation. She gets pain relief when sitting or after applying ice. Maybe in the next visit, the patient reports that they're able to walk 20 minutes before starting to experience knee pain. And now you're documenting improvement. That's great. Pain goes in the subjective section. Pain is subjective. It's not objective. Even though we're putting numbers on it, sometimes it's not subjective. I mean, it's not objective, it's subjective. There's no painometer. You can't measure pain. It's not objective. So here's a list of things that you might mention in the subjective section, but make sure it includes functional application of that related to the patient's main limitation. So chief symptoms, current symptoms, their goals, their functional. So if the patient says, I still can't do this, that has to do with the patient's goals. Social or health habits, if they say, well, I really haven't been doing anything since my injury, I just sit around and watch TV. That's a social and health habit. Health and medical history, like, oh, I can't really stand long enough to make dinner, so I haven't been eating that well. That's relevant information that affects their function, their current pain levels, their response to the last PT treatment, aggravating and relieving factors, their work environment or their employment status. If their injury affects their work, is that improving? Are they able to do their work now? So pretty important group of things to get in there. And sometimes you have to dig to get the information. Ask open-ended questions. So in the objective section, it includes data. My new catchphrase is data or it didn't happen. So this can include pre and post measurements or observations that are meaningful to your treatment, like postural observations. You can document a lot in objective beyond measuring range of motion or strength. range of motion, observations and measurements of edema, functional outcome measures, and we'll talk about functional outcome measures a bit later, sensation, strength, balance, skin integrity, skin inspection, vital signs, test results. If you do a Berg balance test or retest one section of the Berg, the data results go in the objective section. If you do a 5-time sit to stand, the time that you measured on the stopwatch that it took you to do it goes in the objective section. So you'd say 5 times sit to stand equals 10 seconds or however long it took them. Posture observations, level of assist, mount or type of cues required. You're measuring objective data because that's how you're going to show whether the patient is making improvements or not, as the case may be. Edema and girth measurements are pretty relevant in an immediate post-surgical patient. Neurological testing, proprioception, cognition. You could say the patient's ability to perform home exercise program was limited by cognition. Maybe they just they can't do something like that. Maybe you have to simplify their program. You can include outcome measure results. So patient-reported functional outcome measures include things like the Oswestry Low Back Pain Index that we'll talk about later, Neck Disability Index, the DASH Shoulder Assessment. This is something that you or your front desk staff can have the patient complete in the waiting room while they're waiting for you or near the end of treatment. Put those results in the objective section too. You need objective, measurable, repeatable data. A lot of times we'll have people do the Oswestry at their initial evaluation and then halfway through and then at the end and compare the data. So as a section of the objective section, we also include the treatment. So the treatment section has to include clear descriptions of the PT interventions you provided, and including the parameters and the reasons for the intervention. So the reasons for the intervention, we're going to talk, as we talk about each modality, we'll talk about indications, like when would you use it? That's a good thing to put for your reason. So your indications, your reasoning, that's going to guide your charges as well. We'll talk about charges in a minute. So you want to describe the skilled therapy you provided, including the parameters and reasons. For example, let's say you did ultrasound, you might document CUS, which stands for continuous ultrasound, which means ultrasound at 100% duty cycle. But CUS, 3 letters, you say all that stuff, times 10 minutes to lateral knee, 1 megahertz, 1.5 watts per centimeter squared. Those are our parameters to increase tissue extensibility and improve knee flexion. Patient positioned in short sitting for passive knee flexion to 90 degrees. So all of that links back to hopefully a goal of improving their knee flexion. I don't know, because I just made that up and I don't have a real patient. But so nursing notes focus on monitoring the patient, but therapy notes need to show active, skill-based intervention to support medical necessity. So for each treatment session, document not only what you did, but the parameters used, why you did it, and why the activity requires the therapist's skill and decision making. And why can't they just do it at home? Why can't you just delegate this to a non-licensed caregiver, like an aide or something like that? What about this treatment required the skill and training of a therapist? So what makes it skilled? Why is therapy necessary? Address functional deficits and the complexity of the intervention, not just a list of exercise. So you need to include the list of exercises too, but you have to describe what you did while the patient performed them. Were you providing verbal or tactile cues? Were you correcting their form? If you were doing those things, write that down. That is skilled therapy. That's what we provide beyond just telling people a list of exercises to do. Document patient education and cueing levels. For example, instead of writing added single leg bridging 2 times 10, that doesn't really show any skill. You could write instructed patient in progression of bridging exercises to include single leg bridge for improvement of gluteus maximus contraction to improve sit to stand. Wow, all that skill, and we tied it into a goal. That's great. You could add that if cueing is required for the patient to perform the exercise accurately, you could add that in. So the patient required verbal and tactile cues 50% of the time for gluteus maximus contraction. Say what part of the plan of care you're addressing. So we're addressing hip extensor strength to improve their sit to stand, and the plan of care might be to improve their sit to stand. So that's the part of the plan of care that we're addressing. In the assessment, you are documenting the patient's response. Why did the patient need skilled therapy? How did they respond to the skilled therapy? Was there improvement? Look back to your objective data to prove that there was improvement. You want to back up your claims that you make an assessment with measurable objective data. So are they maintaining function? Did they decline? How many cues and what types of cues, verbal, tactile, visual, were needed? So there are lots of different examples of how you might document this. You might say patient required verbal cues 50% of the time to perform this task accurately. Or patient required a fluctuating amount of cues or a variable amount of cues to perform this task adequately. That shows that they still need skilled therapy because they're not going to be able to do it with just their caregiver giving them the cues that you taught them. What adjustments did you make based on the patient's response? For example, decrease resistance on new step from level 3 to level 2 due to the patient's report of right knee pain. You made a skilled assessment and you made an adjustment in their treatment based on that. The main thing you want to document is in the assessment section is functional changes, how they reacted to today's treatment, progress towards goals, and remaining limitations. What's keeping them from being ready for discharge? You're showing that they still need to come to therapy, or maybe they're done. Maybe they have met all their goals, and if they have, we'll then discharge them. That's good. So the plan, you could also in the assessment section state whether certain goals have been met. So you could say short-term goal of whatever has been met, or something like that. If you're going to talk about goals, that's good. And back it up with objective data. So in the plan is what you or the next therapist will do in the next section. How are you going to progress from today's treatment? Don't write what the patient will do between now and the next session. Include a specific progression of treatment for the next visit. This can include specific plans for progressing exercises, location of the treatment, especially if it's changing. You can include a progression from passive treatments like modalities to more active treatments or plans for further assessment, like reassess the Berg or reassess their manual muscle strength, something like that. You can include new activities that you're going to try at the next PT treatment. So introduce stair training next session. That's a good thing to write in the plan. If you're following a specific protocol, a lot of times surgeons will have a post-surgical protocol for a specific type of surgery, like an ACL repair. So you might write progress to week 2 of surgeon's protocol if you're following a specific protocol. The plan might include discharge planning, like plan for discharge within 2 visits if patient continues to progress towards goals. So one of the things that we need to talk about is legibility. It's not as much of a thing with electronic documentation. In electronic documentation, you still have to use correct medical terminology. Electronic documentation does reduce the need for extensive abbreviations. And so my thing is, when in doubt, write it out. But it also eliminates the need to read someone's handwriting, so it's always legible, which is really nice. You want to write in the present tense, and that represents that you're documenting at the point of care as much as possible. Make sure there are no spelling errors. Use spell check. That's another benefit of electronic documentation. Your note should be signed and dated with your name, comma, SPTA, which stands for student PTA. It's your title at this point, your credential, and the date. Most electronic medical record systems automatically sign your name and credentials and date, but since we don't have an EMR, We are going to use word processing for our electronic documentation. And so you don't need to use a fancy font to represent your signature. Just type your name, SPTA, and the date. That's all you have to do. That was one thing I was always getting dinged for when I was in school. I'd leave my name off stuff. So one of the things that you can do to save time in your notes is to develop a template for phrases that you use a lot. You could use a Google Doc or a Word doc or something that you can refer to when writing your notes to speed up your note writing. You can do this in the clinic, but most instructors in the program will not allow you to do this during a lab practical, just so you know. So you want to write in real time, document right after the treatment, use objective language and avoid terms like tolerated well or participated without details. You want to describe exactly how the patient responded and what skilled support they will need from you in order to progress. So the billing section of the note includes appropriate CPT codes. The most used CPT codes in physical therapy are therapeutic exercise 97110, which you probably used last quarter, gait training 97116, which you'll use extensively next quarter, and neuro rehab 97112, which we'll touch on this quarter and you'll use it more in future quarters. So for this course, since we're doing modalities, we're going to use a lot of times treatment for a specific modality. We may use neuro rehab for eSTEM, depending on the reason that we're using it. So the billing is a unit is 15 minutes. So think of things in 15-minute blocks. We'll talk more about that. So the CPT codes for physical modalities, some of them are timed where you record the actual minutes for each modality you performed. If you did it for 15 minutes, it's 1 unit. If you did it for 30 minutes, it's 2 units. So in the CPT codes, which is published by the American Medical Association, there's a specific section for PT, and here it is. Here's part of it. And they're in 15, timed codes are in 15-minute increments. So the ones that we'll mostly use in this class are ultrasound 97014, manual electrical stim, and we'll talk about the difference between manual and untimed electrical stim, unattended. Manual therapy techniques, so that includes soft tissue mobilization and myofascial release. There is a CPT code for massage, and we are not going to use that because most insurance companies do not reimburse for that. Neuromuscular re-ed, so re-education of movement, balance, coordination, etc. Sometimes we're going to use electrical stim specifically for neuromuscular re-ed. And when we talk about electrical stim, I'll address that directly. Occasionally, you're going to use self-care / home management training if you instructed the patient in the use of a device or equipment and you spent 15 minutes doing it. Before you use that code, though, make sure that it's covered by your patient's insurance, because if it isn't, then they'll end up having to pay for it out of pocket. So the untimed interventions are codes where whether you did 20 minutes, 45 minutes, 80 minutes, doesn't matter. It's just 1 unit. Whatever you did from anywhere, you're using an untimed code. So it's a specific modality that's an untimed or a no charge intervention. So mechanical traction and unattended electrical stim are the untimed charges that we'll see with modalities. So if you put IFC on somebody's shoulder, give them a call light, set the eSTIM unit to go on for 20 minutes, tell them how to take off the electrodes, that's an untimed charge. It's always 1 unit, doesn't matter how long you do it for. Document how long you set it for, but you're only ever going to charge 1 unit. The no charge interventions, hot pack, cold pack, and ice massage are all no charge interventions. However, we do want to document them you put a cold pack on someone, give them a timer, a bell, or a call light, set the timer for 10 minutes. It's not chargeable as skilled therapy because they could do that at home, right? You're still going to document it because you did it, and there are potential complications and contraindications, but you're not going to charge for it. And a lot of times in the note, you'll say, cold pack to whatever part of the body times 10 minutes, and in parentheses, no charge. Some EMRs will make you document a no charge code. And that's the code you use. If you that 97010. We'll talk more about that. So the 8-minute rule, it confuses many students. But think of it as if you think in 15-minute blocks, you can't go wrong. So for timed base codes, which are the ones on the left side of this slide, not untimed or no charge, but timed base codes, usually they specify you have to provide direct treatment for at least 8 minutes to qualify to receive reimbursement from insurance for one of those codes, including Medicare. So CMS, the Medicare Services Agency, developed the 8-minute rule, but applies to all insurance companies. If you perform at least 8 minutes of an intervention, then you can charge 1 unit, even though 1 unit is still technically 15 minutes. When they calculate the number of billable units for a particular date of service, the payer, the insurance company, adds up the total minutes of skilled one-on-one therapy, divides the total by 15. If 8 or more minutes are left over, you could charge for another unit. If 7 or fewer minutes remain, then you can't bill for another unit. It can be confusing, but don't worry about it too much right now. If you think in 15-minute increments, you can't go wrong. You can think of the 8-minute rule as 15 plus or minus 7 minutes. So between 8 and 22 minutes, I have a chart here. Between 8 and 22 minutes, you can charge for 1 unit. If you do 22 minutes of soft tissue mobilization, you can only charge for 1 unit of manual therapy. But if you add another minute, increasing it to 23 minutes, you can charge for 2 units. So between 23 and 37 minutes, you can bill for 2 units. Between 38 and 52 minutes, you can bill for 3 units. 53 to 67, 4 units, etc. So think of 15, 30, 45, 60, plus or minus 7. If that's confusing right now, don't worry about it because we'll work on it.